So, is there a way to move the projector a little bit so that we have it all up here? Maybe just a little bit. Okay. This particular slide, I remembered a time in my younger days when my grandmother made the cover of the local newspaper because the homecoming had been in town and she had been on the chair swings. I don't know if any of you know what those are. They're on chains and they swing you out. And she just absolutely loved them. And she happened to be 80 years old. And the caption under that was, "Youngsters of all ages enjoy the homecoming." And so my project is called BRASS, Behavior Reduction Across the Spectrum for Seniors. And so I thought it was appropriate to give you a pictorial representation because of grabbing the brass ring, which is to live your life to the fullest, as they say. So I'll start off where we're having a little bit of discussion about a restraint. And what I'm finding is that we still find ways to try and justify the use of inappropriate medications. And recently I was in a facility that the behavior does not warrant such chemical restraints. So for our definition here, it's for when medications are used for convenience or discipline, prevention or restriction of movement, not required to treat a medical condition, and for symptoms and disorders not approved by Health Canada. They're not a restraint to treat symptoms of psychiatric diagnosis such as psychosis associated with schizophrenia or other mental illnesses, or as part of specific care plan. And this is the key. It's about, if we're going to use these medications, to make sure we have the appropriate assessment, the appropriate monitoring, and that it is written in a plan of care that is going to then be reviewed and updated on a regular basis, that they're not on it forever. This movement that I was a part of back in the late 90s to go chemical and physical restraint free in one of the facilities I worked at was a result of people would be put on an antidepressant. I know when my husband died, the first thing the doctor tried to do was give me Valium. Here, take some Valium. This is a stressful situation. And I didn't want any medication. But many people were coming into our facility, and for 20 years, they'd been on a medication for just that thing. They were giving something in a situational crisis, and it was never reviewed and never taken off. So that's part of where that movement came from. So initially, the BRASS project is to enable residential facilities to better manage behavioral incidents on site and to hopefully prevent acute admissions to deal with behaviors. Many facilities use the acute system as an extension of the residential care facility. So when there's a behavior, they believe the hospital should be the one to stabilize that person and stabilize the behavior. And I'm saying I think that we can do as good a job in many cases in the facility and avert that admission. To reduce the use of antipsychotic medication as a first line of treatment for persons with behavior. To develop confidence and capability of the frontline staff to use internal core behavior teams to review behavioral incidents, and to provide consultation services to residential facilities, both IH and private partners, to help them learn these skills and develop those teams internally. So currently in the South Okanagan, there are 3 facilities that I'm working with to develop these internal core teams. And Village by the Station is a private partner. We're doing, unfortunately, the training. Originally I had wanted to do 3 days of 7-hour training. And due to financing and budget, they said, can we work with it a different way? So each one of these facilities is trying the training with their staff in different ways. So one of them I'm doing half-hour increments. The other one I'm doing 1 hour to 1.5 increments. And the other one is going with the original plan of full-day training. Now, then what we do is we will be meeting weekly with the core behavior team, reviewing behavioral incidents that have happened in that facility for that week and determining what next. What's the next step? What questions do we need to answer? What assessments do we need to do? Take a look at the medications and the whole 9 yards. I did one last week, somebody that's prone to UTIs, having a lot of different problems, and as I'm sitting there reviewing, I counted up the amount of acetaminophen, and this person's on 3,975 milligrams of acetaminophen per day. And I said, you know, I'm not the medical specialist, but maybe you could talk to the doctor about maybe we need better pain management. So this person doesn't have so much acetaminophen in their system because, you know, we're causing other problems by using this much medication. So the other thing that we do is then we review the residents, see if there's any progress, update the care plans as needed, and continue to progress through that. As I said, I'm also providing, at this time, on a term limit position, consultation to all of the IH private and IH facilities throughout the region. So anyone can fill out a referral form to me in our region, and then I will consult with them, and we will go through the exploratory process, and I will try and help the staff in identifying what the behaviors are and what needs to happen. On occasion, I have gone to the locations to do a further assessment and training with the facility and make recommendations as to the care planning process. Some of the education that they receive and some of the tools that we use are the PIECES 3-question template. Any of you who are not familiar with PIECES, it's a great program that was developed in Ontario. And there's a lot of information if you just Google PIECES for care healthcare, and you can go to their site. Gathering history on them, doing a life timeline on our residents, gathering collateral information from any other source that we can, reviewing their medications, ruling out medical causes such as pain, visual disturbances, etc. Following, again, the PIECES framework for assessment, which asks that we look at the physical, intellect, emotional, capability, environment, and social self. So we look at all those aspects of the person and using other assessment tools as necessary. So if I heard this once, I heard it 1,000 times as I was growing up from my father. You can't know where you're going till you know where you've been. And we hear so often, well, I don't have any information. This person is 90 years old. They have no family left. There's nobody to tell us. We have a great niece who was never involved with them. And I challenge you that you can find out about this person. You just have to dig for it. So this is a little cheat sheet that I also came up with because I talk to facilities and staff. The best tool you have in your arsenal is the most complete history you can find on that person. Whatever that information you have, it never ceases to build. So as they are with you, you learn more about them. So their history hasn't stopped until the day they die. So just because you have this much history, as they're in your facility, they're going to teach you more about themselves. There's going to be those lucid moments when they're going to discuss something from the 1930s, or they're going to make a comment to you that you're not going to understand what that word means, like beeling. I ask people that word all the time because my mother called me one time and said, Sandy, do you know what beeling means? And I said, yeah, Mom. I said, it means when I get a splinter, it gets pussy and it works its way out. And she goes, I just wanted to make sure because, you know, one of our newer nurses here, she didn't know what that word meant. And I'm finding that as I use some of those old words from days gone by, my mother would be close to 90 by now, if she were still alive, that the younger generations don't know those words either. And so you may learn some things language-wise. So we have, what are their habits, their daily routines, practices, entertainment, hobbies? What was their work schedule? What was their sleep pattern? And I use that a lot because my sleep pattern, I've never slept a full night. I'm always up in the middle of the night. And right now, let me watch the news, give me caffeinated coffee, and I will go back to bed for you. But don't give me decaf, and don't give me a sleeping pill. Ideals and interests. Are they a simple person or a logical person? What type of communication did they like? And the reason this is important is I tend to be a chatterbox. But there may be some of you here in this room, and some people in your facility, that are very black and white. They want to hear A plus B equals C, get to the point, and shut up. And you walk into their room, and you're chattering away. They're going to give you a behavior eventually. So it's important to find that out. Self-reports. What are they saying to you? I got called to a facility one time, cute little 93-year-old, and I sit down and I say, I understand you're having some problems with the staff. She sits up straight in her chair and she squares off her little shoulders and she cocks her little chin at me and she goes, they think they're the boss. I'm the boss. I don't need to go any farther to know what's the problem. I know where the problem is. She's not feeling that she is being listened to. Her needs are not being met in the way she feels it needs to be met. And we need to explore what's the approach that's been used. Time. How many snowbirds do you have in your facility? Probably a lot. And they know when these seasons change. And they know that something's not right in their world. They can't quite tell you that, geez, I'm supposed to be in Arizona or Mexico. But they know they're not supposed to be here, and they want to go somewhere because that's been their pattern for years. So what did they used to do? Observations. What do you notice? Pay attention to what they're showing you. The rights. This is probably one of the most difficult areas when I'm trying to explain to staff. There's a clear difference between rights and privilege. And so oftentimes when some residents come into a facility, they and their family believe they have just entered a 5-star hotel with room service and a concierge and all of those other services. And that's not the case. So when it comes to behaviors such as causing injury with an electric wheelchair because they are running into people, or breaking things, or they're getting stranded outside because they're slipping off of the sidewalk with their chair and they are no longer safe to drive, that is a privilege, just as driving a car on a road is a privilege. And while we don't want to hinder their independence, we do have to look at the safety issue, and sometimes we have to address those challenging issues with our residents. And years gone by, you heard Dina talk about doing a timeline and going back for a walk through history. This is a very valuable thing to do with your residents, especially if you don't have a lot of history on them. Start with their date of birth. What happened in their lifetime? What might have affected what they're doing now? The period between 1940 to 1965 was a very trying, interesting, exciting time in history. So there was war, there were crises, there were a lot of assassinations. You had Al Capone, and you had, the rum running under moose jaw, I guess it is. So there was a lot of things going on there. Very much male-dominated world. Women entered the workforce in the 1940s during the war. You get your hoarding behavior sometimes because during the wars and during periods of trying times that we haven't had to experience, every little piece of metal meant something. Every little scrap that you collected might have meant you got food in your mouth, or it might have been valuable to you somewhere along the line. Okay? When we raised the children, starting in the 1950s and 60s, our culture did a big shift. And there was more of a focus on self-esteem and how we raise children. So the generations coming up after this generation are very much different, as was said earlier. You don't have to have an absolute understanding of everything before you develop a plan. And I put this up here because it's something that is so abstract. I don't know who thought of mixing a spider with a goat to get silk strands that you could use in Kevlar and medical procedures, but somebody was brilliant to be creative enough to say, I'm going to give it a try. And that's all we're asking you to do, is give it a try. So the next slide, I use this because we're more sympathetic to children. And if you look at these expressions, we can see what these children are saying. Especially this one up here in the corner, no more, right? No more. That's from infancy. But when we look here, we don't have the same sense of compassion oftentimes when we're looking at these faces. And I want to ask, how do we get the compassion back that we had for this slide when we're looking at these faces? I ask people to be more descriptive about the terminology that they use. And I'll tell you one more story here, and then I will speed up the process here. We oftentimes get into a power struggle with our residents about what is fact, what is real, what is needed. And so this happens to be the story of how my name changed to Mike when I was a care aide, and I used to have long hair, and I pulled my hair back in a ponytail because then I didn't lose so much of it. And this one woman started calling me Mike because she thought I was a guy. And then a girl named Michaeline started working there, and she goes, you know, she had to come up with some more details of her story, and she goes, you know, there's another Mike here, but it's not my Mike. But I know that Mike is not her name, but I talked to her mom, and her mom said it's okay that I call her Mike. And I love my Mike. What's important here is not that she knew my name or didn't know my name. I was okay with being Mike when I walked in her room because I gave her a sense of security. Mike was somebody she trusted. Mike was somebody she loved, and she allowed Mike to give her care without being aggressive. So we need to look at the cause and effect behind our behaviors. One word quickly on bathing. We don't often stop and ask why people don't like to bathe. We just know that it becomes a problem as people are elderly. But their skin changes. It's thinner. That's why you have skin tears and you have bruising. And, you know, is the water too hot? Is it too cold? Is the pressure too much? We don't ever stop to ask those questions, and we don't even have the capability in many of our bathrooms to change the pressure of the water, if that might be the case. We need to be creative. Had a resident that if you told her she was going skinny dipping, she didn't beat the crap out of you. And I like to attribute that to the don't throw the baby out with the bathwater. Because in the olden days, the men got the water first when it was hot and it was clean. And by the time you got to the last child, it was black. So skinny dipping was a way to have fresh water. How many steps does it take to get to the Tootsie Roll? No. To set a mousetrap. How many steps? See, I figured this out. The first time that I ever did this, we said, lay it on a flat surface, and the guy held up the mousetrap and immediately went, okay, it's on a flat surface, now what? When we tried to do these instructions. I came up with 10 instructions to set this mousetrap. The ones today are much easier. Throw them up against the wall, let them go. But we talk all the time and give way too many instructions to our residents. We go on and on and on. And as was said earlier, I just changed the slide a little bit. Do you have 15 minutes to prevent a behavior now, or do you have 2 hours of your time to document on why it happened? We have many challenges in collecting data. I won't go into a lot of it, but you can see here we have aggression. It goes in the behavior category. Attempted suicide in the behavior category. Emergency restraint, behavior. Emotional abuse, behavior. Financial abuse, behavior. How do I know what a behavior is when this is how my data is collected? The other thing is in licensing reports. Only if they require medical care does it need to be reported to licensing. So again, I'm only going to get a piece of the picture. So it's really up to the facilities to track their behaviors. And this was just one chart that I had for aggression violence as a cause of injury in our region. Thank you.